So good afternoon. I'm Dr. Jacqueline Lee from the Chinese University of Hong Kong Obstetrics and Gynaecology Department. So welcome to the webinar BRCA Hereditary Cancer Disease organized by our university. I am and I will be sharing this webinar today with my colleague, Dr. Kei. So we know that more and more patients with BRCA mutations are being diagnosed nowadays with the advancement of precision medicine. So today we'll talk about various important aspects of BRCA. So it's our honor today to have Dr. McVeigh from Royal Marsden Hospital London with us, and also Dr. Danny So, Research and Development Scientist from Pangenia with us. So I have to thank our sponsor, Pangenia, for making this event possible. So Dr. So will give us our first talk about technological advancement in BRCA sequencing in recent years. Dr. So studied biology in the University of Hong Kong and obtained a Master in Neurology in 2012 and a Doctor in Biomedical Science in 2017 from the University of Hong Kong. Dr. So has extensive research experience on molecular profiling of solid tumors and had collaborated with Hong Kong University on various cancer researches. So without further ado, so let's welcome Dr. So. Dr. So, please.
Yeah, I got this. Thanks, Dr. Lee, for the introduction. Can you all hear me?
Yes, we can hear you.
Yeah, all right. Thanks. I'm Danny, the R&D Scientist from Pangenia. And here I disclose that I'm the PI of the research projects supported by the ITC, and that's the end of my disclosure. So today I will share with you all some of the screening methods related to BRCA genes with particular focuses on sequencing technology. Before I can talk about things happened in recent years, I have to bring all of you back to 44 years before, when everything about DNA sequencing started that time in 1977. And from that year, without minimizing the importance of the discovery of the structure of DNA much earlier in 1953, there are many technological advancements and key events in DNA science, including newer and better sequencing methods that led to some greater successes, for example, the completion of the human genome and the 1000 genome project. I think all of us should be familiar with the term Sanger sequencing. It is the very first generation of DNA sequencing method. Before it became the mature method we use in a routine manner, it was all manual. The science behind Sanger sequencing is the utilization of terminator nucleotides that are modified to have low 3' hydroxy group that leads to the stop of sequence extension during DNA synthesis. Mixing them with the normal nucleotides in the correct ratio test to be around 1/100. These terminators incorporate into the sequence randomly in the process and at different lengths. When you perform gel electrophoresis, slab gel made of polyacrylamide gel at that time on these fragments, due to size difference, and you can separate them and read the base one by one across different lengths to get the full DNA sequence, but only at 100 to 200 bases in a single one. Sanger and his team completed the sequencing of 5X, a bacteriophage with single-strand DNA genome, in a few years' time. The 5X genome is only 5,000 something bases long, and it took years to be completed. Still, it is by that time the most simple and rapid method. Since the successful development of Sanger sequencing, efforts have been made to speed up and scale up the method. The availability of fluorescent dyes and CCD camera replaced the use of radioactivity and X-ray film, like the peaks I show here. And together with multi-channel capillary electrophoresis, the sequencing steps could be automated. PCR development, synthetic primers, and better polymerase allowed more rapid and reliable DNA preparations. And then better computer power helped to allow automatic base calling and analysis. All these simultaneous advancements make the sequencing of the human genome possible. Then in 2003, after 13 years, of the establishment of the Human Genome Project, the sequencing of the 3 billion bases of the human genome was completed, all based on first-generation sequencing technology using shotgun sequencing, with the input from scientists from 20 institutions in 6 countries and spent $1 billion. And the efforts to decode the human genome benefited also the identification of the genetic factors that contribute to breast and ovarian cancers running in families, those early onset cases, and in some populations. Intense efforts to isolate the BRCA1 gene were made since it was mapped to chromosome 17q in 1990 and 1991 by linkage analysis, investigating familial breast cancer and familial ovarian cancer respectively. The complete sequence of the BRCA1 gene was obtained in 1994, and the sequence of BRCA2 was completed a year later in 1995, only 1 year after it had been mapped to chromosome 13q. During these studies, single nucleotide variants and small insertions and deletions require small indel of the BRCA1 and BRCA2 genes were identified. To genetically screen for these mutations, the first cancer risk test became available commercially in the US in 1996. The company offered BRCA1 mutation sequencing service to their employees and women of Jewish background. The wife of the director at that time of the company, Mrs. Truman, received the test and considered to remove her breast and ovaries after learning that she had the mutated BRCA1 gene. So people know that there are risks associated with BRCA mutations, but how high is that? After many years of research, we now have more data and thus better estimations on the lifetime risks of individuals carrying a pathogenic variance in the BRCA genes. For breast cancer, the absolute risks posed by the pathogenic mutations in the 2 genes are similar at 16%, around that. But for ovarian cancer, the risks associated with BRCA1 mutation nearly doubled than that of BRCA2, hitting also 60%. BRCA1 mutation then has a bigger role to play in inherited ovarian cancer. Although endometrial cancer is not a part of the hereditary breast and ovarian cancer syndrome, latest research suggested also an increased risk caused by germline BRCA1 and BRCA2 mutations. This figure shows the lifetime breast and ovarian cancer risks in BRCA germline carriers. I remember that the lifetime risk of ovarian cancer in BRCA1 pathogenic variant carriers in Hong Kong should be 44%, and that for BRCA2 pathogenic variant carriers is 17%. Here, obviously, is a bit high, but these risks also always subject to the effect of ethnicity. Besides, ovarian cancer patients with germline BRCA1 and 2 pathogenic mutations do show better overall survival and progression-free survival if their disease is at earlier stages. And this effect is found to be stronger in germline BRCA1 mutation carriers. Therefore, it is not only about lowering the risks. BRCA1/2 mutation status do show some values in prognosis. BRCA1 and BRCA2 genes are large in size, having over 20 exons and coding sequences or over 5,000 and 10,000 base pairs respectively. With the earlier attempts of BRCA1 and BRCA2 mutational screening in different populations, the breast and ovarian cancer genetic predisposition is increasingly understood, and it is known that the ethnic differences exist. Different founder and recurrent mutations have been reported across different populations, including the Caucasian, African American, Hispanic, and Australia. But that being said, founder or recurrent mutations are not common. And one thing is clear, all the existing mutational spectrum data point to the fact that there is no mutational hotspot for BRCA1 and BRCA2 genes. Pathogenic mutations are indicated as black dots, and these black dots are present throughout the whole gene. On the left, it is the BRCA1, and on the right, it is BRCA2. There are some mutations being reported more frequently as reflected by the length of the stalk attached to the black dots. But as I said, mutations can occur in every part of the genes. So, in terms of screening strategy, one cannot only screen for BRCA founder or recurrent mutations on these 2 genes and adopt it as a routine test. However, it will be extremely labor and cost intensive for using conventional sequencing technology to sequence the full gene of BRCA1 and BRCA2 due to their size and number of exons. Then there were attempts to speed up the process. HRM, high-resolution melting analysis, is the most commonly used method. The science behind HRM is actually the melting process for checking qPCR product and primer specificity. It's routinely used for qPCR experiments. It monitors the changes in fluorescent intensity over a range of temperature in small increments, typically range from 70 degrees to 80 degrees Celsius. When temperature increases, then the double-strand DNA starts to dissociate, and this is the melting process. And then the fluorescent dye that originally bound to double-strand DNA lost its binding and its fluorescence. HRM uses better dye rather than just the usual one we heard of, cyber green, for sharpening the signals. That is why it is called high resolution. Differences in nucleotide compositions in the DNA strands affect the temperature at which it melts. Abnormalities in the DNA will be reflected in the melt curve. Then we can select the region showing differences in the melt curves for Sanger sequencing. It reduces the use of sequencing, enters the turnaround time, and calls in an effective manner. Here I show you a typical melt curve in a genotyping experiment. You can see that a difference in a single base will result in changes in the melt curve, the TG in blue, TT in gray, and GG in red. HRM technology has therefore adopted as a fast screening pre-screening method for BRCA sequencing since 2008, using many amplicons to cover all the coding regions of BRCA1 and BRCA2, as I show here. Here's a typical HRM experiment for BRCA1 and BRCA2 pre-screening performed in our laboratory. You can see that there's a gap between the red and the blue curves in each melt curve figure. It reflects the fact that there may be changes in the DNA sequence in our client's BRCA2 gene. Then we use the Sanger sequencing to sequence these two regions only. And we found that there's a 1362 A to G variant and a 2-base 571H to 5719 CT deletion. After checking databases, including BRCA exchange, we reported the pathogenic variants to the ordering clinicians. This is the operating procedure for HRMP screening-based BRCA sequencing service. But we should be cautious enough to know that the consequence of a false negative result, so that we should always review the tests and technology we are using every day. I personally like this code so much, and no one wants to get into trouble because of a false negative result, no matter is the client, the clinician, or the diagnostic lab. Here I show you a study in 2017 comparing the technologies in use for BRCA mutation screening in European diagnostic laboratories. One of the participating labs in this study failed to identify mutation in the BRCA2 gene. They used HRM as a pre-screening method. The problem was caused by the fact that the melt curve profile was too similar to a long polymorphic variant, and then the lab just did not spot it. And so low Sanger sequencing was performed to confirm the sequence change. This is a human error, but a similar error can also arise from a double mutation like I showed above. I'm not saying that we should never use HRM again. No, it is still a fast and reliable method. Yet we need to be cautious. And when a better technology exists, we should make a change. Here comes to next-strand sequencing. It sequences by synthesis. It is capable of sequencing many targets simultaneously, unlike the Sanger sequencing method that handles only one fragment in one reaction. Come first. I'm here sharing the technology adopted by the platform Illumina. The first step involved the addition of adapters to our template fragments of interest. These fragments will then be able to attach to the flow cell. This is where the sequencing actually takes place. A cluster of multiple identical fragments will be generated by the amplification of a single fragment, like I show here. Then the positions of these clusters will be registered, And sequencing begins by incorporating dye-labeled nucleotides in sequential cycles. These incorporations, the light and its color emitted from the dye will be red. Then the sequence of each fragment will be obtained. You can see lots of these color spots, and they represent many fragments. And so this is called massively parallel sequencing. This method of sequencing can easily handle all exons of BRCA genes in a single one. I make this lead to help you all see the differences in the first generation and next generation of sequencing technologies. NGS allows the interrogation of many samples and many targets at the same time. So in the setting of BRCA mutation screening, this NGS technology is a better choice. To note, Sanger sequencing detects single nucleotide variants, as I said, the SNV and small indel. NGS does the same, but with better bioinformatics pipeline nowadays, it can detect LGR, the large genomic rearrangements too, although it has a little bit lower sensitivity. So why should we care about large genomic rearrangements? It's because SNVs and indel account for the majority, say 94% of pathogenic mutations in BRCA1 and BRCA2 genes. Latest efforts, however, have found that over 6% of pathogenic variants in BRCA1 and BRCA2 genes are due to large fragment insertions or deletions or duplication. It can be as long as 500 kilobases. LGRs are more commonly observed in BRCA1 gene, and as BRCA1 mutation pose higher ovarian cancer risks, if we screen only for SNVs or small indels, we may miss the true target, and around 7% of patients may suffer from the genetic test results. To cover also the LGS, MLPA, multiplex ligation-dependent probe amplification, can be used. It's a PCR-based method using a large set of specially designed probes. Each MLPA probe consists of two adjacent oligonucleotides, the left arm and the right arm. If they bind specifically to the target sites, ligation takes place later, and then they form the mature MLPA probe. Subsequently, only the ligated probe can be amplified by PCR. And because these probes are designed to have different lengths for different exons or regions on the gene, after electrophoresis, compared to reference samples, the relative copy number of targets can be determined. This method is widely used and discovered 82% of BRCA1 LGRs. This is the electropherogram generated after capillary electrophoresis of the amplified probes. I think you can see that there are some taller peaks. When I draw a line here, it should help a little bit here. All these peaks can be analyzed by calculating the ratio of the area under curve compared to those in reference samples. All three probes for BRCA1 exons 13 are duplicated, and this is found to be pathogenic. In several articles published within last 2 years, reviewing the recent technologies on BRCA sequencing, I just showed two of them, these two citations here. They all agree that NGS as the first step plus MLPA as the second step is the most effective procedure in BRCA1 and BRCA2 routine molecular screening. This is so far the best method. Well, it is not surprising to see that there are other genes involved in DNA repair mechanisms to pose risks to breast and ovarian cancers, like how BRCA1 and BRCA2 do. Provided that NGS has the capacity to interrogate multiple genes and multiple targets at the same time, other genes indeed are drawing more and more attentions. In particular, for ovarian cancer, homologous recombination repair genes and these related genes like the BRIP1 and RED51D pose higher than 10% lifetime risks to its mutation carriers. And carriers with mutations in the Leach syndrome genes, those in MMR mechanism, have even higher risks, reaching up to 20-something%. So it should be considered whether or not include these gene targets in the screening of inherited breast and ovarian cancer syndrome. The latest NCCN guideline also shows that there are clinical management options for the mutation carriers of the above genes. However, whenever we introduce more genes into the screening panel, we always need to think about the possible benefits of genetic screening and the risk assessment and the harm it may bring to our clients. as it may lead to the identification of a lot of variants of unknown significance and issues of overdiagnosis. So here's the summary. You may forget or ignore everything I have said so far for the last 30 slides, but this is the most important one, so take it home. There is no nutritional hotspot in BRCA1 and BRCA2 genes. NGS is an efficient screening method that allows the sequencing of all the coding sequence of the regions of the BRCA genes. And with the combination of both NGS technology and MLPA technologies, we can detect single nucleotide variants, small indels, and LGRs that may be pathogenic in these genes for a more comprehensive BRCA mutation screening to allow better clinical management. So thank you.
So thank you very much, Dr. So, for giving us such a detailed talk on the technological aspects of BRCA genes. So if you have any questions, we will have the Q&A session at the end of the webinar. So you can type the questions in the chat room. So now we'll have a short video from Pangenia before the second talk.
In our laboratory, hundreds of clinical specimens are processed every single day. These samples go through different journeys here. Most, if not all, start from the extraction of genetic materials that store the secrets behind diseases. From manual extractions to fully automatic isolations, we benefit from the advancements in science and technology, like all the remaining steps. Using different technologies, using different strategies, we have assisted the making of decisions by clinicians, decisions by patients, or decisions by those who care preciously for what to do next with their lives. Looking for clues to health conditions can be like searching for a small and dim star in the galaxy. It takes many steps, but for every step we make, we take a step ahead for healthcare. We are Pangenia.
Okay, thank you, Dr. So, for bringing us that video on an introduction to Pangenia. Our second speaker for today is Dr. Terri McVeigh. She is a consultant clinical geneticist from the Cancer Genetics Unit of the Royal Marsden in London, UK. She specializes in cancer genetics and completed her early training in Ireland, and have since then obtained clinical and research fellowships from the Royal Marsden, Yale University, and also the renowned QIMR Berghofer Medical Research Institute in Brisbane, Australia. She has also been rewarded a PhD from the National University of Ireland. She has special research interests in application of genomic testing to direct cancer treatment and clinical education, and is currently also a core tutor at the Imperial College in London. It is our honor to have her here today with us. She will be providing us with her insight into BRCA hereditary cancer diseases and genetic counselling. Thank you, Dr. McVeigh.
Thank you, and many thanks to the organisers for the kind invitation. I'm just going to try and share my slides now. Oh, sorry. Okay, can you see my presentation okay?
Yep.
Fantastic, brilliant. So it's good morning here in London, but good afternoon where you are. So I'm delighted to be with you today. I'm going to speak for about half an hour about BRCA-associated cancers. Much of what I'll talk about today is the practice that we do in the UK, so that may be slightly different to what you do locally, but hopefully it will be along the same lines. So I've just got a couple of disclosures there, different honorary and research grants. But this talk is obviously free from influence. For today, what I want to briefly touch on, I want to give a little overview of the genomic evolution of cancer, I want to talk a little bit about typical driver variants that we see in ovarian cancers. Obviously, the thrust of today's talk mainly is to discuss management of those individuals that carry constitutional pathogenic variants in BRCA1 or BRCA2. And I'm going to touch very briefly on other heritable risk factors for ovarian cancer. And of course, Danny has just mentioned some of those in his excellent talk as well. So some of you may be familiar with this figure. I use it in an awful lot of my talks because I think it's a beautiful graphical representation of what happens as a cancer cell develops. So if we pretend for a second that we're born without any genetic changes, which of course is a fallacy because all of us carry different genetic variations, but even if we were born without any such factors, as we move throughout our life, we're exposed to different endogenous and exogenous mutagens. And basically, as our cells continue to grow and divide over time, they acquire different genetic aberrations. Most of those are completely inconsequential, so they're what we call passenger mutations, and they don't confer any advantage to the cell in which they occur. But if you acquire a particular pathogenic variant in a proto-oncogene or a tumor suppressor gene, that might confer a growth or survival advantage to that cell, and they're what are called driver mutations. And if you get the right, or I suppose the wrong combination of driver mutations, that prompts the cell that was once normal to become increasingly dysplastic or even neoplastic over time. Some people, however, are born with inherent genetic mutations that predispose them to developing cancer over time. So they're the kind of variants that we try to detect, because of course, if you know that somebody carries a constitutional pathogenic variant that increases their risk of cancer, what you can do is try to institute risk reducing strategies to minimize their risk of developing cancer over time. If we think about drivers in ovarian cancer, so ovarian cancer is a fascinating cancer in terms of genomic aberrations. And it's really nice because actually the histopathological subtype of ovarian cancer very nicely matches the kind of genomic aberrations that we can see. So the pathologist can tell me this is a high-grade serous cancer, and I can nearly predict what type of driver mutations I would expect to find in that particular cancer type. For today, obviously, we're going to focus predominantly on the epithelial ovarian subtype, and most particularly the high-grade serous type of ovarian cancer. As Danny mentioned in his talk, a significant proportion of high-grade serous ovarian cancer is caused by pathogenic variants in genes that are involved in homologous recombination repair. And knowing whether or not your ovarian cancer is due to some kind of variant in the homologous recombination repair pathway is very critical in terms of determining what treatment you might offer, because those ovarian cancers that are HRR deficient are much more likely to respond to platinum-based agents. They're also much more likely to respond to PARP inhibition. So about 40% or so of high-grade serous ovarian cancer is homologous recombination repair deficient, and a significant proportion of that is due to either somatic or constitutional variation in BRCA1 or BRCA2. And you can see actually a significant chunk of all high-grade serous ovarian cancer is caused by constitutional variants in either BRCA1 or BRCA2. So we recommend germline genetic testing to all women with high-grade serous ovarian cancer, irrespective of their age of diagnosis and regardless of their family history. So when we think about cancer, it's really important that we consider two genomes. So I've just mentioned that most cancer occurs because of sporadic genetic changes that are acquired over time. So they're somatic events that are literally limited to the cancer cells. But obviously, if somebody has a germline variant, so a constitutional variant in a particular gene, that variant will be present not just in the cancer cells, but also in all of the other cells in their body. And it'll usually be detectable on a blood test. And they're the types of variants that can be transmitted to their children and to members of the wider family. So when we think about how constitutional variants in BRCA1 or BRCA2 are inherited, the cancer risk associated with these variants is inherited in what we call an autosomal dominant manner. So we each have two copies of the BRCA1 and BRCA2 genes. The reason we have two copies is we get one copy from our mum and one copy from our dad. And if we look at this example, if we pretend that dad here has a pathogenic variant in BRCA1, each of his children will have a 50-50 risk of inheriting the pathogenic variant from him. And if a child inherits the pathogenic variant from him, that child will then be at risk of cancer. So it's a flip of a coin. Every child has a 50-50 or 1 in 2 risk of inheriting a pathogenic variant from their parent. And that's the same for males and females. And I think sometimes the general public and actually some doctors forget that male patients can carry these genetic alterations. They're at increased risk of cancer, and obviously they can transmit it to their children. So it's important that men as well as women in these families have access to genetic testing. If we think about the risks associated with pathogenic constitutional variants in BRCA1 for a second, and again, Danny mentioned some of these in his previous talk, the greatest risks associated with pathogenic variants in BRCA1 are for women, and the greatest risks are for breast cancer. So the risk is anywhere between 60 and 90% over a woman's lifetime. The risk of ovarian cancer is anywhere between 40 and 60%, but there are other risks. And in male carriers, for example, there's a slightly increased risk of male breast cancer. There's also a slightly increased risk of prostate cancer. And we know for both male and female carriers, there's an increased risk of pancreatic cancer, and possibly, although it's uncertain, whether or not there's an increased risk of melanoma. BRCA2 variants, by comparison, again, the cancer kind of phenotype is very similar. The risks are slightly different but overlapping. So women, again, have a very high risk of breast and ovarian cancer. Male carriers in this instance have a higher cancer risk. So males have a significantly increased risk of male breast cancer. They also have a significantly increased risk of prostate cancer. And again, the risk of pancreatic cancer in these carriers is higher. And there is a well-established link between melanoma risk and BRCA2 constitutional variants as well. So again, if we go back to what's the likelihood of finding a constitutional pathogenic variant in BRCA1 or BRCA2 in a woman with ovarian cancer, it really depends on the underlying subtype. So we know that about 1 in 5 women that have high-grade serous ovarian cancer will carry an underlying constitutional pathogenic variant in one of these genes. We also know that we can find these variants in women with endometrioid subtypes, sometimes with clear cell subtypes, much rarer in other subtypes. So we don't tend to offer germline testing to women with mucinous subtypes or carcinosarcoma or low-grade serous, because they're much more likely to be related to other genetic factors. So let's think for a second about the cancer risks in carriers of these variants. The risks that I've just quoted to you are empiric risks based on all of the different variants, and they're just kind of, that's why we give a broad range. There are lots of things that can influence the individualized risk estimate that we give to a woman. So obviously the risk is gene and gender dependent, as we've just said, but also it can be variant specific as well. So there are certain variants within BRCA2, for example, that don't confer the same high risks that I've just spoken about. So there are certain variants within BRCA2 that are actually only associated with a moderately increased risk of cancers. It's very important when you find a variant of that nature that you know that it's associated with reduced penetrance, because you may manage those patients very differently compared to how you would manage people with the very high risk variants. We also know that there are certain locations within BRCA1 and BRCA2 that are associated with differential risks of breast and ovarian cancer. There's a region in BRCA2, for example, that's associated with much higher risks of ovarian cancer than in other parts of the BRCA2 gene. We also know that there is an age-related penetrance. So if we think about ovarian cancer, the risk of ovarian cancer in a BRCA1 carrier is extraordinarily high over the course of her lifetime, but actually that risk doesn't really start to increase until about the age of 35. So a woman at the age of 20, even if she carries a pathogenic variant in BRCA1, her risk of developing ovarian cancer at that age is actually quite similar to that of the general population. And that's the rationale for not launching in with your risk reducing strategies until the woman is a bit older. So we tend to introduce our risk reducing strategies around the age of 35 or even closer to 40 for BRCA1 carriers, and actually a little bit later for BRCA2 carriers. And I'll talk a little bit about that later on. The other issue is coexisting genetic modifiers of disease. So we know that there are other genetic modifiers of cancer risk scattered throughout our genome. And of course, these variants are not mutually exclusive. So if a BRCA1 or BRCA2 carrier, for example, inherits other, 20, 30, 40 single nucleotide polymorphisms that influence their cancer risk, that can push her cancer risk up or down depending on the loci in question. And we're getting to the stage where we're actually offering polygenic risk scores alongside our high and moderate risk gene panels in order to stratify and provide an individual risk estimate to women to help guide, decision making about timing or whether or not she even avails of risk reducing surgery. There are lifestyle and environmental risk factors to consider as well. So much like in the general population, we know that there are lifestyle and reproductive factors that contribute to an increased or decreased risk of breast or ovarian cancer. When we look at those lifestyle and environmental risk factors in BRCA1 and BRCA2 carriers, the data is a little bit more messy because, of course, if you have a very high risk genetic risk factor, that kind of trumps everything else. The data around a lot of these is quite muddled. What we do know is that the oral contraceptive is a very important thing to consider. There is potentially a slightly increased risk of breast cancer if you use the combined oral contraceptive for more than 5 years. But the flip side of that is that if you do use the oral contraceptive pill for more than 5 years, you actually reduce your risk of developing ovarian cancer very significantly, almost by about a half. So really, we leave it up to the woman herself to do a risk-benefit analysis. You know, there's probably no benefit to be gained from being on the combined oral contraceptive for more than 5 years. So we, you know, can sort of have a discussion with her to say, look, your risk of ovarian cancer now is reduced because you've been on it for this period of time. You're probably not going to reduce it any further, but your breast cancer risk might now start to increase. So that's when you might consider introducing non-hormonal contraceptive alternatives. But it's very important to take a holistic overview for these women. Oh, sorry. So let's talk a little bit about how we manage these cancer risks. And I'm going to focus first of all on the ovarian cancer risk management. And I know we have another speaker that's going to talk a little in more detail about this later on. When we think about ovarian cancer screening, this is always very contentious. And of course, the criteria that we use to guide our screening programs in the UK is based on the Wilson and Younger criteria, which were determined back in the 60s. And if we think about those criteria in relation to ovarian cancer fulfills some of these criteria. The screening tests that we use fulfill some of these criteria, but not all of them. So the jury is really out as to whether screening is appropriate for this particular type of cancer. In the UK, we often use what's called a risk of ovarian cancer algorithm. So this algorithm basically considers the age of the woman in front of you, her menopausal status, her genetic risk, so whether she's a BRCA1 or BRCA2 carrier, and serial blood measurements of the CA125 biomarker. The UK Familial Ovarian Cancer Study looked at this algorithm in very high risk women, offering ROCA screening every 4 months. If the ROCA test was normal, they were then offered a transvaginal ultrasound annually. If the ROCA test was abnormal, obviously they were offered a transvaginal ultrasound much more promptly within 2 months. Of the 4,348 women screened, a fifth of them withdrew. Almost 200 of them needed surgery, and of those 149 underwent surgery for a false positive scan. There were 19 cancers diagnosed within the first year of screening, but of those, over a third were stage 3B or stage 4. So the authors of this study, who I work with very closely in London, suggested that this type of screening might be useful in terms of inducing a stage shift, but they haven't as yet proven that there's a definite mortality benefit to this approach. So at the minute in the UK, we don't actually advocate for screening. The only proven method at the minute of reducing your risk of ovarian cancer is to undergo risk-reducing bilateral salping oophorectomy. And obviously the pros of this is that it significantly reduces your risk of ovarian cancer by about 96%. It can't eliminate the risk completely, and obviously there's going to be a residual risk of primary peritoneal disease. Another advantage to this is that it might reduce the risk of breast cancer by up to a half if undertaken before the age of 50, although the data about that is a little bit contentious as well. That only applies to BRCA2 carriers because, of course, BRCA1 carriers are much more likely to get cancer that is not estrogen driven. So removing your ovaries is not likely to have a huge impact in breast cancer risk in those women. Obviously, there is significant disadvantages to the surgery. So as I said earlier on, the age at which we tend to introduce this is around the age of 30 or 40. And obviously that's a lot younger than the age at which a natural menopause would typically occur. Obviously, it has implications for fertility, and certainly in the UK, a lot of women haven't even contemplated starting having a family until the age of 35. So that's a huge issue in these carriers. We know that there are significant health risks to a premature menopause, including an increased risk of heart disease, an increased risk of osteopenia or osteoporosis, and an increased risk of cognitive difficulties later in life as well. So to try and offset those disadvantages, we don't recommend this surgery before the age of 35. And actually we tend to try to push it out until the age of 40, unless there's a very strong family history of early onset ovarian cancer. We do recommend hormone replacement therapy to our carriers, and that's been proven to be safe in carriers of BRCA1 or BRCA2 variants until the time at which they would have had their natural menopause. Now, the only caveat to that is if they've had an estrogen-driven breast cancer in the past, in which case HRT is usually contraindicated. There are lots of non-hormonal alternatives that we will consider in those instances. And obviously we recommend DEXA scanning and things like that to make sure that their bone density is maintained. In the UK, we've started this very exciting study called the Protector study. So the Preventing Ovarian Cancer Through Early Excision of Tubes and Late Ovarian Removal. So what this study is doing is comparing the single standard risk-reducing bilateral salpingo-oophorectomy to a two-stage procedure. Initially a risk-reducing early salpingectomy anytime after the age of 35, with a delayed oophorectomy closer to the age at which they would have had their natural menopause. And a third arm is then looking at no surgery. And what the primary outcomes of this study are looking at are actually sexual function and hormone metrics. But obviously the secondary outcomes that they're looking at are to see whether this influences cancer incidence and mortality in these women. The underlying hypothesis behind all of this obviously is that most ovarian cancer in these carriers actually starts in the fallopian tube. So the rationale is that if you remove the fallopian tubes, hopefully you reduce the risk of cancer very significantly, but you spare the woman the significant morbidity of a premature menopause. So we're very keen to see the outcomes, both primary and secondary, of this study in due course. If we change tack now and focus on the management of breast cancer risk in these carriers, there's sort of a three-pronged approach, if you like. So we can either introduce screening or risk-reducing surgery. And there's also the option of chemoprophylaxis using tamoxifen or an aromatase inhibitor. And again, chemoprophylaxis is only really useful in BRCA2 carriers because they're predisposed to getting estrogen-driven breast cancers, whereas it's not as effective or effective at all actually in BRCA1 carriers because they're much more likely to get estrogen receptor negative or even triple negative cancers. In the UK, the screening that we recommend starts from the age of 25 if you've got a very high risk family history, but more typically the age of 30 if you've got a more moderate family history. The type of screening that we recommend depends on the age of the individual and their breast density. So we typically recommend MRIs in women under the age of 50. We do introduce mammograms from the age of 40. From 50 onwards, usually mammogram is okay to use in isolation, but obviously there are some women that have very dense breasts that will require MRI on a longer term basis. A lot of our women opt for risk-reducing surgery. Obviously, this is a big consideration, both physically and psychologically. Most of our risk-reducing mastectomies are undertaken with an immediate reconstruction, and obviously the reconstruction can be as complicated or not as you like, depending on how far up the reconstructive ladder you want to go. We're very lucky in the Marsden, we've got amazing oncoplastic surgeons that are able to do these exquisite free flaps and they get really beautiful cosmetic outcomes. But obviously the decision about what type of reconstruction, if a reconstruction is undertaken, depends very much on the size of the natural breast, the body shape, body habitus, personal choice and surgeon's recommendation. And that could be quite a complicated discussion. It also depends on whether the person is having cancer treatment at that time. Patients always ask me whether there's a survival difference between having risk-reducing surgery compared to having surveillance on a lifelong basis. And actually, we're not completely sure about that. What is pretty evident is that the later you have the risk-reducing surgery, the less likely you are to enjoy a survival benefit. So there is a slight survival advantage if you have the surgery earlier in your life, but that dissipates very, very quickly over time. Obviously, the advantage to having risk-reducing surgery compared to surveillance is that you minimize the risk of ever having a diagnosis of cancer and having to go through cancer treatment. Obviously, whether or not there's a survival advantage also depends on whether you've ever had a preceding cancer diagnosis and whether you've had other risk-reducing surgery like oophorectomy, for example. Increasingly, as our treatment of ovarian cancer has improved, and now the people are thankfully living longer with ovarian cancer and, you know, having longer disease-free survivals, the question about risk-reducing mastectomy has started coming up. after a diagnosis of ovarian cancer. Obviously, there are issues here because, you know, the biggest threat to that woman's life is the ovarian cancer with which she's been diagnosed. Many of these women won't actually survive long enough to derive any benefit from a preventative mastectomy, and the life expectancy may be too short to warrant a surgery. However, there is a potential benefit if the woman was diagnosed at a very young age, if she was diagnosed with very early stage ovarian cancer, and if she's enjoyed a very long disease-free interval. So there hasn't been very much literature about this yet, but Steve Nairod published a lovely paper a couple of years ago looking to see when you might consider risk-reducing mastectomy after a diagnosis of ovarian cancer. They've suggested that you might consider it if the woman was diagnosed under the age of 55, if she's been at least 10 years disease-free, and if she was diagnosed with a CUHK or stage 1 or stage 2 disease. Now that kind of criteria, those criteria are quite restrictive. So we're a little bit more liberal. We will consider it if a woman is 5 years disease-free, and if, you know, she's pretty healthy and there are no contraindications otherwise, but we haven't done it that often, I have to say. If we think briefly now about our male carriers, so obviously we know that men that carry pathogenic variants in BRCA1 and particularly BRCA2 are at increased risk of prostate cancer. And again, surveillance for this particular type of cancer has been contentious. The impact study, which was run by my colleagues in the Royal Marsden, has shown that an annual PSA-based screening programme starting from the age of 40 is effective in male carriers of constitutional pathogenic variants in BRCA2, but longer-term follow-up is required to determine if this is useful in carriers of BRCA1 variants or with a family history or other pathogenic genetic variants. So we certainly offer this to our carriers of BRCA2 variants, but we're not certain yet if we should be doing it outside of that. With respect to male breast cancer, there isn't a male breast cancer screening program as yet. What we do tell men to do is be aware of any new symptoms, so things like lumps or bumps in the chest wall, any changes in their skin, any changes in their nipple, etc. In terms of pancreatic cancer management, again, screening for pancreatic cancer has not been shown to impact mortality from disease. If we think about the risk of pancreatic cancer in BRCA carriers, the risk is increased compared to the general population, but the absolute risk is relatively low. So you're talking in the order of 5 or 6%. Again, that depends on the family history. And if there's a very strong family history, you might have a higher risk estimate for that individual. Screening at the minute in the UK is not recommended outside of research studies. But we do tell BRCA carriers obviously to be mindful of any new symptoms. Obviously, all of this audience will know what those symptoms are, so things like weight loss, new onset diabetes, jaundice, etc., etc. We also tell them to avoid smoking because obviously smoking is associated with an increased risk of pancreatic cancer as well. With respect to melanoma risk, again, as I said, the risk is well established in BRCA2 carriers. The jury's out as to whether there is an association with BRCA1 variants. The risk also depends on skin type. So obviously in the UK, you know, people are quite fair. We don't get an awful lot of sunlight, so we're inclined to not be very sun aware and get sunburned a lot more frequently than we should. So the advice that we give to BRCA1 or BRCA2 carriers to manage their risk of skin cancer is not rocket science. We tell them to try and avoid sunburn. We tell them to use sun cream where possible, to avoid direct sunlight between 11 and 3. Obviously, if people are avoiding sunlight, there is a risk of being vitamin D deficient. So we give them advice about alternative sources and medicinal supplementation if required. We also give them this ABCDE rule. So just to be mindful of any changes in the symmetry, border, color, diameter, or any kind of change in their mole, and seek prompt advice if required. But we don't tend to offer routine dermatology follow-up unless there is a very strong family history of skin cancer. It's really important, obviously, when we think about our management of a BRCA1 or BRCA2 carrier, that we think about their wider family. So obviously we offer cascade testing to the adult relatives because that will inform their risk of cancer in the family. But we also need to think about the next generation. And there are lots of family planning options that should be offered to carriers of these particular genetic traits to try and minimize their risk of having an affected child if that's an option that they want to consider. Many of our carriers, to be honest, just have children naturally and let them make their own decision about testing when they reach adulthood. Some of our carriers, which is really sad, some of them opt not to have children. Now, some of that is because they want to get on and have their risk-reducing ovarian surgery and they don't want the risk of cancer hanging over them. Some women opt for, or some men and women opt for gamete donations, a sperm or egg donation. That means obviously that your child won't be genetically related to you, but obviously that child won't have a risk of inheriting the familial variant from you. Similarly, some people opt for adoption. A very popular option in the UK now is pre-implantation genetic diagnosis. So this is IVF, basically with an additional test. So you create the embryos in the laboratory using standard IVF processes. You then test the embryos for the presence of the familial variant, and you only offer implantation of those embryos that don't carry the familial variant. That's offered publicly funded in the NHS, so couples are eligible to avail of 3 rounds of pre-implantation genetic diagnosis if that's what they want to consider. There are certain criteria, obviously, that they have to fulfill, largely related to the maternal age and BMI and smoking habits. There is also the option of prenatal testing, that can be non-invasive or invasive, depending on whether it's the mother or the father that carried the variant. That is contentious because obviously that then throws up the decision about whether you would terminate an embryo that carries a pathogenic variant in one of these genes with the knowledge that the embryo is otherwise healthy. So I have to say not many of our carriers opt for that particular option, but it's feasible. Danny in his talk mentioned some of the other heritable risk factors for ovarian cancer, and I just want to mention them briefly because, again, they are creeping into our panels more and more. So we've spoken a lot about BRCA1 and BRCA2. Danny in his talk mentioned the genes associated with Lynch syndrome, which we know are associated with the moderate risk of ovarian cancer. He also mentioned the other genes that are involved in the homologous recombination repair pathway, including RAD51C, RAD51D, BRIP1, and PALB2. BRCA1, BRCA2, and possibly the Lynch syndrome associated genes confer a high risk of ovarian cancer, so anything greater than 10%. RAD51C, RAD51D, BRIP1, PALB2, variants in those genes are more likely to be associated with a moderately increased risk of cancer. And then there are a whole heap of different low-risk genetic factors which individually increase your risk only very slightly, but the combined effect of that, or what's termed your polygenic risk score, might actually start to approach that of the moderate or even the high-risk genes. Lynch syndrome was previously called hereditary non-polyposis colorectal cancer syndrome. We don't tend to call it that anymore because it completely undersells how multi-organ this particular disorder is. Obviously, it's associated with bowel cancer, yes, but it is also associated with an increased risk of endometrial cancer and ovarian cancer, as well as a whole heap of other gastrointestinal and genitourinary cancers. About 2 to 3% of ovarian cancer is due to Lynch syndrome, predominantly endometrioid, and clear cell subtypes, rarely the high-grade serous subtypes. So you're much more likely to think of BRCA1, BRCA2, and the high-grade serous subtypes. Ovarian cancer and Lynch syndrome tends to occur at younger ages, tends to be associated with earlier stage disease, and tends to have a favorable outcome. You can screen for Lynch syndrome quite easily using immunohistochemistry to check whether a cancer is mismatch repair proficient or deficient. And again, the risks are gene specific and range anywhere from between 11 to 17% on average. PMS2, the risks don't seem to be massively increased compared to the population, but the other ones certainly are. Again, I've mentioned you can test for them using immunohistochemistry or microsatellite instability. And if you have somebody that has mismatch repair deficient or MSI high ovarian cancer, they should certainly have germline testing of the MMR genes. Moderate risk genes I've mentioned, the RAD51D and RAD51C, they are involved in homologous recombination repair. Variants in these genes, again, are gene and genotype specific and depend on the family history. But you can see there that the cumulative risk of ovarian cancer in a carrier of RAD51C or RAD51D variants can be, in the order of about 20%. So up to 20%. So obviously that's significant and needs management. The risk again depends on the family history. So you can see if there's a strong family history of ovarian cancer, the risk can be anywhere up to 50% over their lifetime. The management, again, as we said earlier, there's lots of issues with ovarian cancer screening. So for these carriers, we tend to recommend risk-reducing ovarian surgery from the age of 40. There is an increased risk of breast cancer, so the management of that really depends on the family history. BRIP1, as Danny mentioned, is also associated with an increased risk of ovarian cancer. This gene is interesting because it was thought previously to be associated only with very late onset disease. That's come into question in recent times. And again, the risk seems to be moderate. These carriers, again, are offered risk-reducing surgery, usually after the age of 45. and breast cancer risk management is guided by the family history because it doesn't appear to be an independent risk factor for breast cancer. PALB2 is coming into play more and more because we know it is associated with a very high risk of breast cancer. It's associated with the moderately increased risk of ovarian cancer. Management in these individuals is really guided by the family history. Yeah, so as I said, risk is the management is guided by the family history. Polygenic risk scores I'll touch on very briefly for the last 30 seconds of the talk. So as I said earlier, there's hundreds of low risk loci that contribute to cancer risk. The combined effect of that might approach that of the moderate or even the high risk variants. Polygenic risk scores are very difficult to develop and to implement. Most of the polygenic risk scores that we've developed have been derived from white European populations, so they're not necessarily applicable to other populations. The difficulty with polygenic risk score is that they can't be used in isolation. You have to interpret them within the context of the family history, other genetic risk factors and environmental and lifestyle factors. But the hope is that we'll be able to use these polygenic risk scores to stratify our risk in our high or moderate risk gene carriers. And again, it's potentially subtype specific. There's new loci being discovered every day, so it's quite dynamic. It's not quite ready for clinical implementation, but it is creeping in. Some of the commercial laboratories are offering it now. We're using it a lot on a research basis, but we haven't yet rolled it out in our NHS routine clinics as yet. So take-home points from this discussion: all women with non-mucinous ovarian cancer should be offered germline genetic testing for variants in BRCA1 and BRCA2 and possibly the moderate risk genes, regardless of their family history. Consider Lynch syndrome if it's non-serous and there's a family history of other Lynch syndrome associated cancers. Consider further testing if there's a strong family history of ovarian cancer. And obviously we need to consider that the results will have implications not just for treatment, but also for future cancer risk and importantly for the wider family as well. Further education, so I just wanted to highlight that I've developed a postgraduate certificate in cancer genetics. This is designed to try and upskill non-geneticists in this kind of complex genetic testing. So you can check that out, www.rcpi.ie. We're actively enrolling at the minute. There's lots of videos and pictures and hopefully things that would be helpful. I've also developed some patient resources, so www.cancergenetics.ie. I've got lots of different videos that are targeted towards patients that go through their options for surgical management, talk about how these things are inherited and their options for family planning. So thank you very much for your attention. I'm sorry I've run a minute over time. I'd be happy to take your questions later on. And again, thank you very, very much for the opportunity to speak to you today.
So thank you very much, Dr. McVeigh. I'm sure all of the audience had a much more comprehensive understanding on the clinical aspects of BRCA and heritable ovarian cancers after your talk. So genetic testing for cancer is actually relatively new to Hong Kong, and as clinicians, we are uncertain how the general public actually view this. Therefore, our department had conducted a study on awareness and acceptance of BRCA screening in the Hong Kong general public. And Dr. Kar Kei, our honorary clinical tutor from the Chinese University of Hong Kong O&G department, will present the findings. So Dr. Yong graduated from the University of Hong Kong and received her specialty training in O&G in Prince of Wales Hospital. She obtained her membership from the Royal College of Obstetricians and Gynaecology UK and is planning to pursue a subspecialty in Gynaecology. So Dr. Yong, please.
Okay, thank you, Dr. Lee, for your kind introduction. Let me just get my slides up. Okay. So thank you. So as both Dr. So and Dr. McVeigh has presented to us in their excellent talks, our knowledge in genetics changes every day, and so does our understanding of hereditary cancer syndromes. Today, genetics now play a role in not only risk assessment and early detection of diseases, but also in directing treatment and management. Worldwide, genetic testing and counseling is also becoming more and more widely available. You can now even order your own genetic test online. However, so far, as Jacqueline has mentioned, genetic testing and screening is still, at least in Hong Kong, not very widely practiced clinically on a day-to-day basis and is still relatively new to our practice. So, however, However, things are changing though. There are currently 2 sets of local guidelines and recommendations regarding BRCA testing, and recently BRCA testing has also become available in our public hospital network. And we have started to offer testing for patients with ovarian cancer in order to guide the treatment and use of targeted therapy. In the community, however, public education regarding genetic testing still appears to be uncommon. Today's webinar coincides with the Breast Cancer Awareness Month, and it would seem like the opportune time to promote awareness and also the importance of BRCA. But still seemingly little promotion in this area is seen in the general public. So therefore, when we first introduced BRCA testing in our unit, we wanted to find out just how much our patients actually know about it. And we were curious to know how accepting they were of genetic testing in general. So we conducted a short survey study recruiting patients from our outpatient clinics and recruited around 300 patients within a 6-month period. It was a short 12-item survey conducted face-to-face in our outpatient clinics. We covered the women's basic demographics, so including their age, occupation, educational background, as well as their monthly household income. We covered their basic knowledge and awareness of hereditary cancer syndromes, and also their acceptance and attitude towards genetic testing. So regarding the demographics, the recruited women ranged from 16 to 65 years old with a median age of 34. The majority of the women were recruited from our obstetrics clinic, and so they fell into the range of 31 to 35 years old. In our particular locality, in our local district, the median age of the population is around 43. So this cohort of women is ranging a bit younger. In terms of their educational level, actually the majority of the women, so up to 70%, achieved tertiary level of education, which is almost double the average educational attainment of women in this locality. For their monthly household income, they ranged from $10,000 to $50,000. And according to the Hong Kong Census and Statistics Department, the median monthly household income in this particular locality is around 35,000 Hong Kong dollars, which falls into this range. So this is compatible with our locality. And for their occupation, most women were either homemakers or worked in administrative positions. Regarding the basic knowledge of hereditary cancers, most women, so up to 87% of our respondents were aware that cancers could be hereditary. But specific to each type of cancer, though, the most well-known hereditary cancer is still breast cancer, and the least number of women being aware that colorectal cancer can be hereditary. Younger women and also women with a higher monthly income were found to have a higher level of knowledge and awareness, which is unsurprising. Most women were aware that genetic testing and prophylactic surgeries are available, and most think that these can improve survival, but it is not very well known that testing can actually direct treatment and management. And specific to BRCA mutations in ovarian cancer, because this is what we've started to do, most women were unsure about its prevalence amongst ovarian cancer patients, and also the significance of having a BRCA mutation. So it would seem that women in general had a general awareness of hereditary cancer syndromes, but not so much the details with regards to hereditary cancer syndrome. Regarding their attitudes towards testing, surprisingly, a large number of women actually were overall quite positive and were willing to undergo genetic testing. They would generally want to know their results if they were screened high risk or tested high risk, and they were willing to share their results with their family members, including their parents and their siblings, and also their sons and daughters. And regarding the clinical significance of testing, of genetic testing, most women think that testing can improve treatment outcome. And if screened high risk, most women were accepting of disease monitoring, as well as prophylactic treatment and surgeries. For example, salpingo-oophorectomy. And only 7% of women expressed fear and anxiety regarding testing. And we found that more educated women were less likely to express fear and anxiety. A small proportion of women were worried that undergoing testing would have adverse effects on their general health and management of disease, and around half of the women were concerned about the implications on insurance. So finally, about funding, the expected price of genetic testing seems to be around $5,000, with the majority of women finding a price of less than $2,000 acceptable. Now, as far as I know, the price of genetic testing varies depending on the laboratory, depending on the panel and number of genes you're testing for. But insofar as I know, and do correct me if I'm wrong, Dr. So, a simple BRCA1/2 panel, if done in a private lab, should cost around $4,000 to $5,000. And as for who should be paying for the genetic testing, just about half of our respondents feel that testing should be fully paid for by the government, and the rest are happy with a subsidized arrangement. So in summary, although our cohort of women, given their relatively younger age and also higher educational level, may not be truly representative of the general population, they do show an overall basic awareness and knowledge of genetic testing and hereditary cancer syndromes. And their overall attitude towards testing seems positive and receptive. And this forms a promising and encouraging foundation for us to hopefully continue to broaden our genetic testing services here in Hong Kong. Thank you. So next up, we have our last talk for today. Dr. Jacqueline Lee will talk to us about cancer risk reducing strategies in female BRCA carriers. Dr. Jacqueline Lee is the Associate Consultant and Honorary Clinical Associate Professor of the Department of Obstetrics and Gynaecology here in the Chinese University of Hong Kong. Dr. Lee received her Gynaecology training in Prince of Wales Hospital and furthered her training in the UK and France. Dr. Lee specializes in gynaecology, laparoscopic and robotic surgery, and also holds a master's degree in medical genetics. She is also the president of the Hong Kong Society for Colposcopy and Cervical Pathology, board member of the Hong Kong College of O&G Gynaecology Subspecialty Board, and was just awarded the Distinguished Young Fellow from the college earlier this year. Dr. Lee, please.
Thank you very much, Dr. Yong, for the kind introduction. So today I'll talk about cancer risk reducing strategies in female BRCA carriers. So Dr. McVeigh had already gave us an idea on the various strategies available, and my talk will focus also on the evidence behind these recommendations. So just an introduction, we should have listened to this for a few times already in this webinar. So the estimated lifetime cancer risk for BRCA1 mutations for breast cancer and is around 80%. For ovarian cancer is around 40 to 65%. So BRCA2 mutations, BRCA cancer is around 80%. Ovarian cancer is less than BRCA1, is around 20%. So BRCA mutations actually accounts for around 4% of breast cancers and 24% of epithelial ovarian cancers. So there are different ways to reduce the cancer risk in this kind of patients. So first is increase in surveillance. So clinical breast examination, MRI breast, mammograms, ultrasound breast for breast cancer, or maybe CA125 and transvaginal scan for ovarian cancer can be performed. And second thing, it's chemo prevention. Tamoxifen, raloxifene, and aromatase inhibitors may reduce the risk of breast cancer, and COC pills can reduce ovarian cancer, as Dr. McVeigh had said previously already. So I'll talk about these in the following slides. And last is prophylactic surgery. So we know that bilateral mastectomy, bilateral cervicofractomy, or the more recent one, the bilateral subinjectomy with a delayed ovarectomy can reduce ovarian and breast cancer very significantly. So this is the European and the United States guideline. So in general, both of them recommend annual MRI breast from around 25 age, 8 of 25 onwards. And clinical breast examination, it's recommend every 6 to 12 months from 25 onwards. And the European guidelines had recommend 6-monthly transvaginal ultrasound scans and CA125, but it's only a level 5 recommendation. So it's just expert opinion because there's actually no studies showing a survival benefit with this approach. And therefore, in the United States guideline, this is actually not recommended, although they add a clause that it can be considered if the patient had not received RRSO, which is risk-reducing saprophyrectomy, at the age at around 30 to 35 years old. So COC pills is recommended for ovarian cancers reduction, and bilateral mastectomy and also risk-reducing saprophyrectomies are recommended. And the European guideline recommends it at 35 to 40 years old, and the United States guideline recommends it for BRCA1 patients at 35 to 40 years old, and for BRCA2 patients, because the risk is actually lower and it starts to develop ovarian cancers at a later age, the age is recommended, it's 40 to 45 years old. So first I'll talk about the surveillance. So breast surveillance can be done by MRI, which is actually the most sensitive method in high-risk group, so BRCA high-risk group. So from the age 25. And mammogram can also be performed from age 30 onwards. So, but this is less sensitive than MRI. And it has a problem that it may be affected by the breast density, especially if the patient is young, less than 40 years old. And the reason for not recommending it before 30 years old is because there are some studies showing that the radiation associated with mammogram may increase the risk of breast cancer if the patient is before 30 years old. So ultrasound is also another method if MRI is not available. So it can act as an adjunct to mammogram. So this is a prospective study on MRI breast. So it includes 445 BRCA women with 850 controls having annual MRI versus no MRI. And the follow-up time is 6 years, and they follow up the incidence of ductal carcinoma in situ, early stage and late stage of breast cancers. So you can see that for the MRI group, the type of the invasive cancers actually is less than the control group. And the risk of early stage disease is also higher in the MRI group. And you can see that the size of the tumor for the MRI group, it's also more of them are in the smaller size group, whereas in the control group, the tumor size is larger, and also the tumors that are node positive is also higher in the no MRI group. So you can see that for no MRI group, there is more invasive cancer, less DCIS, larger tumors, and more node negative disease. So you can see from this chart, so the incidence of having a stage 2 to 4 breast cancer is actually lower in the MRI group, and this early stage disease is higher in the MRI group because surveillance just detects the cancer earlier, but not prevent cancers. So the chance of having an advanced invasive cancer, which is 2 centimeters or node positive, is actually less in the MRI group, and the hazard ratio is 0.3. So how about MRI versus mammogram? Actually, a lot of studies have been performed, prospective, retrospective, on these two modalities in high-risk BRCA carriers or patients high risk of having breast cancers because of a strong family history or with personal history of breast cancer. So you can see that all of these studies done in several European countries all show a high sensitivity with MRI, much higher than that of mammogram. So the sensitivity of MRI, it's around 70 to 100%, while that of mammogram, it's only around 20 to 40%. And the ultrasound also just shows similar sensitivity with mammogram. So of course, if the sensitivity is higher, then probably the false positive rate will also be higher. So the MRI, it's also found to be associated with lower specificity than mammogram, with more false positive results, and therefore the callback rates of having MRI will be higher, leading to more biopsies being performed, so around double that of mammogram, and of more cancers can be diagnosed if MRI is done. So MRI is a recommended imaging for surveillance in BRCA patients. As for ovarian cancer surveillance, as previously discussed, there's actually no data showing that any method can reduce the mortality. So it's generally not recommended, both in both European and American guidelines. Although even if it's recommended, it is only a level 5 recommendation. So next, I'll talk about chemo prevention. So we know that tamoxifen can reduce breast cancer. So in this large RCT with more than 10,000 women of larger than 60 years old, or 30 to 59 years old with a 5-year predicted risk of breast cancer of at least 1.66%, they calculate it with some criteria, and with history of this low CIS or atypical hyperplasia, they either take tamoxifen or placebo for 5 years. So you can see that the risk of invasive cancer and also non-invasive cancer are both decreased in the tamoxifen group, so the black dotted lines. So the cumulative invasive cancer rates for tamoxifen, it's reduced from 42.5 per 1,000 women to 24.8 per 1,000 women. So the relative risk is 0.57 with taking tamoxifen. And it also reduces the chance of having a non-invasive cancer. But of course, tamoxifen is associated with other problems. We all know that it is associated with endometrial cancers and also pulmonary embolism and other types of thromboembolism. So we have to discuss with the patient. So tamoxifen can reduce non-invasive breast disease by 50%, reduce estrogen receptor positive cancer by 69%, but then it also increases endometrial cancer by 29% and increases risk of pulmonary embolism by 11%, and also have some side effects with vasomotor symptoms and vaginal dryness and dysreunia. So when we prescribe tamoxifen, we have to warn the patients of this risk, and they should seek medical attention early should they have any suspicious symptoms, for example, intermenstrual bleeding or postmenopausal bleeding. So that is tamoxifen in the general high-risk population. But how about specifically in BRCA carriers? So this is a case control studied in 209 patients with bilateral breast cancer. So they have breast cancer in certain time point of their life, and then subsequently develops another breast cancer in the other breast. So the other control group is 384 patients with unilateral breast cancer. So 80% of them are BRCA1 positive and 20% of them are BRCA2 positive. And they fill in whether they had used tamoxifen with a self-administered questionnaire. So you can see that the first breast cancer is usually diagnosed at around 30 to 50 years old. And should they have a second breast cancer, is diagnosed at around 45 years old. So you can see that tamoxifen actually decreases the risk of contralateral breast cancer. The odds ratio is 0.5. And the decrease is actually increasing with a duration of use up to 4 years. So if you use 4 years of tamoxifen, the risk reduction is 75% of breast cancer in the contralateral breast. So it's also found that bilateral subophthalmectomy can reduce breast cancer. The odds ratio is 0.42, probably because of the removal of the estrogen. And chemotherapy is also found to reduce breast cancer with an odds ratio of 0.4, and that probably is because some of the occult tumor cells in the contralateral breast are being treated with the chemotherapy, and therefore affecting the chance of developing a breast cancer in the contralateral breast. So raloxifene and aromatase inhibitor, I just like to word on it. It had been shown to reduce breast cancer in high-risk women, raloxifene, and aromatase inhibitors have been shown to reduce breast cancer in postmenopausal high-risk women. But there are not no studies specifically studying this issue for BRCA carriers. COC pills, Dr. McVeigh had told us just now that it's very good for reducing ovarian cancers, and it also can reduce endometrial cancer. So this, there are 45 studies in 21 countries showing the longer use of COC pills, the greater reduction, and the risk reduction per 5 years use, it's 29% if it's used within 10 years, and 19% if it's used within 10 to 19 years. So the 10 years use of COC pills can reduce ovarian cancer from 1.2 to 0.8 per 100 uses, and it can reduce mortality from 0.7 to 0.5 per 100 uses. So it's good for ovarian cancer, but then there are concerns on breast cancer. So the data on breast cancers are a bit conflicting, although there's a meta-analysis in 2014 showing that there's no increased risk of breast cancer with COC. So we can still discuss with the patient and give them COC pills if they're at high risk of an ovarian cancer. So then I'll talk about risk-reducing surgery, which is the most effective way of preventing cancers. So I'll first talk about bilateral risk-reducing mastectomy, so RRM. So it's very effective, although there are no RCTs, but there are multiple prospective and retrospective studies showing a 90% risk reduction with risk-reducing mastectomy. So it can be a total mastectomy, or skin-sparing mastectomy, or nipple-sparing mastectomy. The latter two are associated with better cosmesis. The safety data is not so much, but then they are encouraging, although some people were worried that for nipple-sparing mastectomy, it may be associated with slightly higher risk of breast cancer. Then you can offer immediate breast reconstruction after the mastectomy. So the things to consider with mastectomy, it's of course the psychosocial aspects. So there may be decreased sexual satisfaction and negative body image in the patients. It's associated with surgical risk, and there may be symptoms which are prolonged even after the surgery, like numbness or pain in the wound and the skin. So there are quite a lot of studies showing that mastectomy is very effective in reducing breast cancer, prospective, retrospective, with few hundred participants, all show that if risk-reducing mastectomy is performed, the risk of breast cancer is around 0 to 3%. As compared to the group with no mastectomy being performed, the risk of breast cancer is 8 to up to 50%. So it's really a big difference between the two groups. So these studies have shown a 90 to 95% breast cancer risk reduction with mastectomy. So what age should it be performed? So then we have to look at when breast cancer develops in these BRCA carriers. So in general, as previously said, the risk starts to increase from around 40 years old. So by 40 years old, the risk of having a breast cancer for BRCA1 carriers, it's around 21%. For BRCA2 carriers, it's 17%. And by 50 years old, the risk of having a breast cancer for BRCA1 patients is 39%, and for BRCA2 patients is 34%. So you can see that if you're going to perform a mastectomy to reduce the risk of breast cancer, you cannot perform it too late. So because many of the patients may already have developed breast cancer. So how about mastectomy of the contralateral breast if the patient already had breast cancer in one breast? So this is a Dutch multi-cohort study with 583 BRCA-associated primary breast cancer in 30 years with a follow-up of 11 years. So there are 42% of them having contralateral mastectomy and 58% of them just receiving surveillance. And in a contralateral mastectomy group, the chance of having a contralateral breast cancer, it's only 2%, versus in the surveillance group, 19% of the patients developed contralateral breast cancer. So the mortality, it's also lower in the contralateral mastectomy group. So it's 21.6 compared to 9.6 1,000 person years of observation. So the hazard ratio is 0.49. So it's still effective in reducing the chance of having a contralateral breast cancer. So it can reduce the risk of contralateral breast cancer from 19 to 2%, and also reduce breast cancer related deaths. So the survival benefit is most prominent in young patients, of course, because they have longer survival usually, and early stage cancers because of the better survival again, and no triple negative phenotype, and those not requiring adjuvant chemotherapy. So in general, lower risk cases with higher chance of a survival will benefit more from a contralateral breast mastectomy. So, and how about reducing mastectomy in ovarian cancer survivors? So this is a stimulation study. The numbers are estimated from the Canadian and International Registry on BRCA carriers and evaluates the reduction of deaths associated with mastectomy and MRI surveillance. So these studies found that in 509 BRCA carriers with ovarian cancers, eventually 3.9% of them developed breast cancers. So the actual risk of having a breast cancer at 10 years, it's 7.8%. So if you just look at the stage 3 or 4, so the advanced stage ovarian cancer patients with a diagnosis at age 50, the breast cancer risk is only reduced by less than 1% by MRI and less than 2% by mastectomy. So it's actually not that good reduction in risk. So when you look at this chart, so this is the chart in those without ovarian cancer, you can see that prophylactic mastectomy and MRI both reduce the mortality compared to the red line, the no MRI group. But then if the patient has breast cancer, actually these 3 lines just comes together, so the difference is eliminated. But when we take up the early stage ovarian cancers only, so stage 1 to 2 cancers, you can see that the lines are separated again, so there may be still a beneficial effect for prophylactic mastectomy and MRI in the early stage ovarian cancer patients. So this is because these ovarian cancer patients have high risk of dying from ovarian cancers already. So the survival will not be very long, and the clinical or benefit of a prophylactic mastectomy would be diminished because of this. So greater improvements in survival with mastectomy can be seen in those with a good prognosis ovarian cancer. So early stage ovarian cancer patients, or those with already long-term survival, so more than 10 years of survival in ovarian cancers. These kind of patients will benefit more from the mastectomy. So next I'll talk about risk-reducing cyclorectomies. So this is a prospective study, multi-centered cohort in European and America with more than 2,000 BRCA carriers. So 10% of them had risk-reducing mastectomy and 40% of them had RRSO. So we can see that the ovarian cancer risk and the breast cancer risk are both much lower in the RRSO group, and the death is also lower in the RRSO group, so 10% versus 3%. So RRSO can reduce the risk of ovarian cancers, a breast cancer, death from all cause, death from breast cancer, and also death from ovarian cancers. So the ovarian cancer reduction is 70%, death reduction is 40%. The data on breast cancer reduction, it's relatively controversial, although the studies show a significant result. But then some of the recent studies show that actually there's no clinical benefit. So RRSO in BRCA carriers, it's found in this meta-analysis to reduce ovarian, fallopian tube, and breast cancers by 80%, with a 0.2 hazard ratio for ovarian and fallopian tube cancer and 0.49 hazard ratio for breast cancer. So when should it be performed again? So we can see that by 40 years old, the risk of having a breast cancer in BRCA1 and 2 is around 2 to 3%. But if it's 50 years old, the risk in BRCA1 carriers would be much higher, it would be 20%. The risk in BRCA2 carriers is still not that high. And by 60 years old, the BRCA1 patients will have 40% risk of having an ovarian cancer. So they are higher risk group. So the RRSO distribution depends on the type of mutation, whether it's a BRCA1 or 2, the fertility wish of the patient, family history of cancer, and also the patient's acceptance. So there's a chance of actually detecting cancer already during the RRSO. So if the RRSO is done at a younger age, for BRCA1 carriers, the chance of having occult cancer is around 2%. So this risk is not that obvious in BRCA2 patients until 60 years old. But for BRCA1 patients, the chance of an occult cancer actually start to increase substantially until 11% for 60 years old group. So this kind of occult cancers have much better survival rate than a clinically diagnosed ovarian cancer, but of course nobody wants to have an occult cancer anyway. So therefore, because of this age issue, BRCA1 carriers would be recommend to have an RSO at an earlier stage. So it depends on the patient's preference decision. And for BRCA2 carriers, since the age of having ovarian cancers is usually older, they can have it at a later age. So after RSO, actually there's still a risk of peritoneal cancers, but then the risk is not actually that high. It's only around 0.1 to 0.2%. So ESCO had recommended RSO at age 30 to 40, and BRCA1, this is a recap, at age 30 to 35 to 40, and BRCA2 at age 40 to 45. And there is no particular surveillance recommended after the RSO. So next, it's bilateral risk reducing early salpingectomy and delayed oophorectomy. So Dr. McVeigh just now had already gave us some background on this. This is because some of the ovarian cancers actually may come from the fallopian tubes, and salpingectomy had been shown to reduce ovarian cancer. And in average risk women, bilateral salpingectomy have been found to reduce ovarian cancer by 65%. So this idea of having a bilateral salpingectomy first and then delay oophorectomy so that the hormonal function can be retained. So this is a French study on a prelim study on this issue. So it's found, it had 121 such surgeries, and it's found that occult tubal neoplasia, it's found in 0.8% of high-grade serous carcinoma is found in 0.8% of the cases, and tubal intraepithelial carcinoma or lesion is found in around 2 to 3% of the patients. But this strategy still lacks prospective outcome data, so it's still within research settings, and it offers no protection against breast cancer. So if the patient refuses an RSO, you can discuss this with them. So lastly is the lifestyle factors. So previously it's have been discussed. So in this meta-analysis, it's found that BRCA carriers, breastfeeding is protective for breast cancer. More than 3 live births are protective over an oviparous lady, and more than 4 years of smoking increases the risk of breast cancer, and alcohol is now found to have an association. As for ovarian cancers, breastfeeding is found to be protective. More live births of more than 4, it's found to be protective. Tubal ligation is protective, but smoking and alcohol, no association is being found. So this is just a summary of what I've said just now. So in view of time, I would like to see whether anyone has any questions, no matter with this talk or the previous 3 talks. So let me see. So there's one question for Dr. So. Is Dr. So here? Yeah, hello. So some Chen Tech is asking, why are there 2 completion of human genome projects, one in 2003 and one in 2021, and whether we can use whole genome sequencing instead of gene panels?
For the first questions, the reason why there are 2 completions, in fact, the human genome has never been completed. Maybe next year or 2 after some scientists can finish it. In 2003, the versions completed around 92%. Those not sequenced are near the or at the centromere and telomere. Those regions are very hard to sequence with short sequencing method. So they are not able to finish it. And at that time, people still think that those are rubbish genes or areas. So they didn't have much concern about the regions. And then the available, or because the availability of 3rd generation sequencing, they can handle long fragments like 15,000 bases at a time. So they screened it and then they get the sequence completed just this year. But they left the man behind because they used the hydatidiform mole cells to increase the identical chromosomes pair. And then they haven't finished the Y chromosome. So still not yet completed the whole human genome. For the second questions about the WES, right, whole exome sequencing. There's a new paper published this year. They found that all the existing whole exome sequencing kits fail to capture all some of the coding gene. So around 500 of them are affected. Not all the coding genes are covered in the whole exome sequencing. And then one of them we actually mentioned today, the PMS2. It is poorly covered in WES. So I will never advise you to use WES to complete something that you can complete with gene panel. And it also avoid the discoveries of accidental findings. I think the genetic counselors must know the problems with it. And then there's another paper using gene panel for some lung disease. For example, one inherited eye disease panel discovers around 41% of the disease-causing genes, pathogenic variants. And using WES only discovered about 33% of this. So if you know what you are looking at, then you need to use the gene panel instead of WES. It's also about the coverage of sequencing. So it increased the diagnostic use and the quality. So thank you.
Thank you, Dr. So. So there is another questions by Law Wing Yi. So is routine screening for BRCA 1 and 2 for patients with family history but not actually diagnosed to have any cancer, and whether this test is being done in pediatric or referred to QMH. So actually, HA has a program to check BRCA mutations for all advanced stage ovarian cancers starting a few months ago. So it's available in all public hospitals for ovarian cancer patients because of the treatment with PARP inhibitors. So as for the family, so if the patient with ovarian cancer is diagnosed to have a BRCA, then of course the doctors will tell the patient about this and then will tell them there is implication on the family. So if the family members want such a testing, then they can be referred to the Department of Health. Currently, the government-funded genetic testing service, it's in Department of Health, or if they want earlier service, more early interventions, then they may have to go private. So I also have a question for Dr. McVeigh. Hello, Dr. McVeigh?
Yes, hi.
Yeah. Hello. I would just like to ask, actually, how is the uptake of genetic testing in the patients in UK, and also how is the uptake of patients for risk-reducing surgeries in the UK? So do patient really accepts it and does all these testings and treatments? Yeah,
so it's very dependent on some of the factors that were highlighted in the questionnaire in your own group as well, like high socioeconomic factors, that those people all want genetic testing. Like a lot of our patients, the uptake is very high because we work in a very wealthy part of London. So the genetic the test uptake is really high. The other thing we've introduced is mainstream genetic testing. So a few years ago, you could only access genetic testing if you went to see a geneticist, whereas now we've removed that. So oncologists can offer genetic testing during routine appointments, and that has really increased the uptake because if you're introducing more and more appointments, people are less inclined to take up the genetic test. But if you can do it as part of the routine care, they take it up very readily. Where we're not so good is in the predictive testing. So, unaffected family members, sometimes there's a bit of hesitance there. Sometimes people don't really want to know if they're at risk. So we have to work quite hard to encourage people that are asymptomatic but haven't yet developed a cancer to come forward for a testing. In terms of the question about risk-reducing surgery, very mixed. It's a very personal decision. Some of our young women are really motivated to get it done very quickly and as soon as possible. Other people just opt for the surveillance and don't really want to have any surgery at all. So it's very individual. I think our rates are probably higher than other places in the UK because we have the surgical specialists on site. But yeah, relatively high, I think, compared to the rest of the world, yeah.
So I also have a question for both of the speakers. So we know that we can either check for somatic mutation or germline mutation or both mutations. So I heard that Dr. McVeigh actually recommends all patients having germline mutations being checked. So, but is that common in the UK for all patients having germline mutations, or some of the patients will still choose only having somatic mutations because it has less implications on the insurance and also the inheritance to the family members?
That's a very, very good question. I have to say, the people that refuse the germline testing, few and far between, to be honest. You know, there's only a handful of people that refuse. Most people, when you explain the potential implications for their family members, they take it up quite readily. I always worry a little bit about just doing the somatic testing, particularly if we don't find a variant. And Danny mentioned some of this, the complexity of trying to find those larger deletions. Often that's not very possible with tumor sequencing because the DNA is very fragmented and you can't do the long read sequencing very easily. And in the UK, the proportion of mutations that are accounted for by those large genomic rearrangements can be up to about 1 in 5 pathogenic mutations can be large genomic rearrangements, depending on what part of the country you're in. So you'll miss those in the tumor testing. And then, of course, you might deny someone the option of PARP inhibitors if you haven't done the paired germline test. So we very much encourage people to do it as a paired test rather than in isolation if we can. There have been a couple of people, for the reasons you've outlined, some people just don't want to get into germline genetic testing at all, but luckily it's not common at all. Most people do opt for it.
Okay, so I think we don't have other questions. So if that's all, yeah. So there are no other questions. So once again, thank you very much for Dr. So and Dr. McVeigh. It's our honor to have you here with us to share your views on BRCA. And we all must have learned a lot from Dr. So and Dr. McVeigh. So thank you very much for all of your participations, and we hope to see you again in the coming webinars by our department. So thank you, both speakers and also all the audience. So this is the end of the webinar.
Thank you. Thank you very much.
Thank you.